Tiếp theo xin mời báo cáo của tiến sĩ David Pinato với chủ đề là liệu pháp toàn thân có thể cạnh tranh với điều trị tại chỗ trong ung thư biểu mô tế bào gan không? Không thể cắt bỏ. Của giáo sư.
Hello, my name is David Pinato. I'm a consultant medical oncologist at Imperial College London. And today I've got the pleasure of talking about systemic therapy and the relationship with local regional therapy in hepatocellular cancer. These are my disclosures. So what I will be talking today is a little bit of an overview about TACE, which is the only local regional therapy with a significant survival benefit in intermediate stage HCC, how the indications have evolved and how the outcomes have improved over time. When we start and when we stop local regional therapy, the clear boundaries, and how systemic therapy, given that it has evolved quite markedly over the past decade, has integrated or has become an alternative sometimes to local regional therapy in HCC. So whenever we think about HCC therapy, we often think about a sequential approach. A proportion of patients will be diagnosed with curable disease and could either undergo transplantation or local regional therapy in the context of downstaging prior to transplantation, or they would undergo curative therapy straight away, either resection or ablation. Another proportion of patients will present being immediately suitable for local regional therapy. But as you can see from this graph, local regional therapy is often a dynamic process in the broad context of HCC therapy. In a way, a lot of people that get local regional therapy would have had curative therapy before, and often local regional therapy is offered prior to or instead of systemic therapy, and systemic therapy is therefore used at the point of disease progression. There are also a number of patients that are unsuitable for local regional therapy up front, maybe those patients with multifocal disease where we think that local regional therapy is not really going to be effective, and those patients are referred for systemic therapy straight away. And what we are seeing is that as a result of systemic therapy being more efficacious these days, more and more often we're seeing local regional therapy as becoming part of the treatment algorithm in patients that, for example, started with immunotherapy straight away. So the landscape is definitely getting more and more complicated, and this left to right sequence is kind of becoming a little bit more complex to manage. I guess whenever we're dealing with a dynamic landscape, we have to think about the treatment goals and what is the actual positioning of TACE versus systemic therapy. So local regional therapy and systemic therapy are both palliative. And the thing is, the median overall survival for patients that are immediately candidate for local regional therapy is or should be fairly extended if we select the patients right, with a median overall survival projected around 21 months. Over 60-70% of the patients will be alive at 3 years. Obviously, local regional therapy can be repeated. It's a focal treatment, whereas for systemic therapy, surely we have evidence that even in patients with with liver-confined disease, the median overall survival is definitely better than patients with metastatic disease, over 14.5 months in IMbrave 150, for example, the most recent immunotherapy study. But actually, it is a continuous treatment that continues until progression or loss of clinical benefit. So I guess the key questions around the role of systemic anti-cancer therapy and local regional is, do we need it after local regional therapy? And for that, we've got really good level 1 evidence. All of the studies have recruited to patients that have essentially failed local regional therapy. With local regional therapy as a combination, well, we need time for that. There are a number of phase 3 studies that will be reporting probably in the next few years. And the question is also, can we use local regional therapy, systemic therapy instead of local regional? And again, we know that in patients who are ineligible for local regional therapy, we've got level 1 evidence, but we don't have local regional therapy available in patients who are eligible to TACE. So this is a really important point. So TACE is the only local regional therapy with proven overall survival benefit. Most of us will know that it does have a dual ischemic and cytotoxic effect. We have good level 1 evidence in 2 randomized controlled trials and 1 meta-analysis. But there are, as you can see, a lot of different factors that have got to do with the treatment, with the patient, with the tumor burden, and with the hepatic reserve. So TACE is actually quite an heterogeneous treatment. And the point of TACE is to try and prevent adverse events and liver failure by granting a really good survival benefit. So patient selection is actually key to get that delicate balance right. The evidence behind TACE is actually quite old, and there hasn't really been a lot of movement in the intermediate stage HCC space, at least since 2002. You can see here the two trials, one a Western trial led by Lovet and the second trial led by Lowe, where patients were randomized to TACE or control treatment. In the Lovet study, there were also a group of patients that received TAE without chemotherapy. As you can see, there is good survival benefit compared to no treatment whatsoever or symptomatic control. But you can appreciate that nobody would ever treat patients with symptomatic management in BCLC-B disease, in patients with liver-confined disease these days. And actually, if you have a look at the characteristics of the patients that were enrolled in the clinical trials, you can see that a lot of them had Child-Pugh class B disease. They had a performance status of 1 or 2 and had actually evidence of portal vein invasion. So these patients, I argue, might not be fully the focus of local regional treatment anymore. And in real life scenarios, most of these patients will either be recommended to have best supportive care if the performance status is not good enough, or maybe they will go straight away for systemic therapy as such. So as you can see on the right-hand side, you have a really good graph that shows how the median overall survival has dramatically increased at the 3-year landmark from the early studies to the most recent case series published in the late 2000s. And on the left-hand side is the explanation as to why this improvement has been possible. So there are a number of absolute contraindications to TACE. We do no longer treat patients with decompensated cirrhosis or with extensive portal vein thrombosis. And as a result of this, also patients with severe comorbidities, with large tumors, they do not tend to get TACE anymore. And this is the key to sort of optimize the outcomes from a treatment that is surely effective in a proportion of these patients. What is really interesting is that in the real world, TACE is actually given a lot outside the recommended guidelines. So if you have a look at the green bars, the dark green bars, you can see that it's true that the majority of patients with stage B, with intermediate stage HCC, will get TACE, but actually, very surprisingly, a lot of the patients with stage 0 or stage A will get TACE as a first treatment, maybe as a downstaging treatment, or in patients who are not eligible for radical approaches. But actually, I find it very interesting that a lot of patients with stage C, with advanced disease, or even with terminal HCC, do get TACE completely outside of the guidelines. And my mind wonders, are we depriving these patients from more effective treatment options? This is a key issue in real life practice. So we have started to recognize that not all the patients benefit from TACE. And I think in my mind, there are 3 different strategies through which we can go about this problem. So with either further refine the BCLC-B patients, so the patients where there is a clear indication for TACE, we think about alternative patient therapies for patients that do not respond, that have got adverse features. And you can see on the right-hand side, the recent paper published in Hepatology, where you can look at adverse prognostic factors, tumor burden, liver function, and you can guess that a certain proportion of patients will have a very poor outcome from TACE. And the third option is to think about combination therapy, especially now that immunotherapy is up and coming in patients with HCC. It's very important to also define when to stop and to avoid depriving patients from systemic therapy, given that overall survival is not just a function of TACE effectiveness, but also a function of subsequent treatment. And I think in treatment guidelines, patients that fail to respond after 2 cycles of TACE should be discontinued and should consider other treatment options. And as you can see here, a number of other societies have put together criteria, for example, presence of insufficient responses or consecutive progression or increase in tumor markers or new vascular invasion or extrahepatic spread. All these features, either the radiological or biochemical, are pointing towards patients that will not benefit from TACE and in whom early introduction of systemic therapy is key to maintain oncological outcomes. And I think Jody Bruce in Hepatology back almost a decade ago, highlighted what is a good treatment algorithm for TACE, so that if you do get a complete or a partial response, clearly those are the patients that benefit from TACE more. They can have repeat TACE in the future, and unless there is disease progression or impairment of liver function and performance status, TACE can be repeated, hopefully hoping for either a partial or a complete response, but TACE should be discontinued in any case there is no objective response or treatment failure. A key point is to think about systemic therapy instead of local regional therapy. And I think we have good evidence to suggest that both sorafenib and lenvatinib can be utilized in a subset of patients with BCLC-B disease where TACE should be normally recommended. We have sub-analysis from the SHARP trial, for example, showing, as you can see on the left-hand side, the patients with BCLC-B disease had a better treatment time to progression as well as overall survival compared to BCLC-C patients. And in a recent study by Professor Kudo, which is a retrospective study, so again, with all the due limitations, patients that received lenvatinib with liver-confined disease and were matched to TACE controls, as you can see from the Kaplan-Meier curves on the right-hand side, achieved a much better outcome compared to TACE. Again, these is either retrospective evidence or sub-analysis from phase 3 clinical trials. This does not mean that in all BCLC-B patients, there is the immediate need to pursue systemic therapy, especially if they're a good candidate for TACE. But this is definitely provocative in saying that there is a segment of patients that might benefit from systemic therapy in BCLC-B disease. And the same is true for the immunotherapy era. In a recently published data at EASL 2021 by Riyad Salem, we can see that, with atezolizumab and bevacizumab, the median overall survival is fairly competitive, 19.2 months. And a lot of patients in the IMbrave 150 study had evidence of prior local regional therapy, about 50% of them across both atezo-bev and sorafenib. And as you can see from the overall survival, based on number of prior local regional therapy, we seem to be hitting the sweet spot when patients receive 1 or 2 local regional therapy. These patients have a better median overall survival of 22.8 months compared to patients that get a lot of TACE before accessing immunotherapy, where the overall survival is 17.3 months. Again, these are sub-analyses of clinical trials. We shouldn't really put too much emphasis on this because the inclusion criteria were basically patients that were TACE refractory. So again, we can't say that patients should get immunotherapy up front, but this is again very provocative and gives us good indication in terms of when to potentially stop to maximize patient benefit. Another important approach is to consider TACE combinations with systemic therapy. And I think this has been the object of contention. As you can see here, a lot of clinical trials, both in phase 2 and phase 3, have attempted to look at the combination between sorafenib and TACE. The rationale is good. You block anti-angiogenesis after provoking a good ischemic effect to the tumor. But unfortunately, there was no improvement in overall survival, despite evidence of some improvement in TTP and in response rates. The next challenge in my mind when we think about combination therapy is combining TACE with local regional, is combining TACE with immunotherapy. As you can see, there is good evidence to suggest that TACE primes the immune system and might promote immunogenic cell death and engage with the immune system, in particular with antigen presentation and with T-cell cytotoxic activity. And we've got good evidence from this paper by the Flecken group in 2014 showing that TACE enhances CD8 immune responses against renowned tumor-associated antigens. So the rationale is there. We have some more information from my group, actually, that we recently published in JITC, where, as you can see, we looked at the tumor microenvironment of patients that were treated with TACE and ended up having either resection or transplantation. And as you can see here, there is definitely evidence of accumulation of immune cells in patients treated with TACE. The immune infiltrate correlates with survival, and therefore we can potentially suggest that there is an immunogenic potential from TACE that we can see within the tissue of patients treated with local regional therapy. A number of studies are ongoing, including one that is run at Imperial College called PETAL, studying pembrolizumab after TACE. We have published the initial interim analysis showing no toxicity and a competitive median duration of response. Other studies are ongoing, in particular Emerald stage 3, phase 3 study that is potentially due to report fairly soon, and we'll be llooking at the combination with durvalumab plus or minus bevacizumab. A lot of open questions here. What is the right endpoint? How can we interpret the results in terms of overall survival in these studies? And how can we capture the heterogeneity of post-TACE failure? So until these studies are actually reported, it will be very difficult to make treatment recommendations. So in a summary, TACE at the moment remains the standard of care options for patients with liver-confined HCC, but I hope I managed to give you the sense that there are a lot of provocative data invading the intermediate stage space and sort of trying to suggest that because not all the patients will respond to TACE, there is an important need to either consider systemic therapy instead of TACE in a subgroup of patients. And we should probably think about integration between local regional therapy and immunotherapy, but this is essentially the subject of ongoing clinical trial. At the moment, treatment decisions are complex, but are likely to become even more complex in the future, requiring full MDT support in terms of when to think about systemic therapy upfront versus combination or local regional therapy alone. And with that, I thank you very much for your attention.
Xin cảm ơn tiến sĩ David Pinato đến từ trường ung thư Hoàng gia London, Vương quốc Anh. Khi ung thư biểu mô tê gan không thể cắt bỏ, thì liệu pháp toàn thân có thể cạnh tranh với điều trị tại chỗ không? Một câu hỏi rất thú vị. Chúng tôi muốn nhận được các ý kiến bình luận và các ý kiến của hội nghị. Xin mời thầy Hợp ạ.
Cảm ơn giáo sư Sang Hun An đã trình bày báo cáo rất hay về các dấu ấn sinh học mới hiện nay về ung thư biểu mô tê gan. Trong này giáo sư đề ra 3 cái dấu ấn là AFP, lectin 3. Đấy, cái này là nó có thể giúp cho trong để chẩn đoán sàng lọc ung thư gan mà khi trường hợp AFP mà nó không cao thì mình sử dụng cái này. Và cái này thì phó sư tiến sĩ Vũ Văn Khiên đã từng làm một cái đề tài nghiên cứu sinh về vấn đề này. Ông cho thấy vấn đề này. Đặc biệt đây là nói về cái AP mà lectin 3 mà tỷ lệ phần trăm ấy thì có liên quan tới mức độ ác tính và có liên quan tới các dạng ung thư gan. Cái chúng ta cũng thấy rất hay để mình ứng dụng sau này đó. Bên cạnh đó thì sao? Những trường hợp mà AP âm tính thì giáo sư đưa ra thêm một dấu ấn nữa là cái DCP, tức là D gamma carboxyprothiomin. Cái này có thể cũng giúp trong trường hợp mà AP âm tính thì cái dấu ấn này nó sẽ giúp cho ta biết được trường hợp bệnh nhân nó có chẩn đoán sớm ung thư và cũng giúp cho vấn đề đáp ứng cái điều trị và theo dõi tái phát ung thư. Đấy, hai cái dấu ấn này rất là quan trọng đó. Bên cạnh đó thì trong đó đây là cái viêm ung thư gan có liên quan đến viêm gan B. Còn đây thì lúc trước chúng ta đã nghiên cứu rất nhiều vấn đề HPV DNA, nhưng bây giờ trường hợp mà HPV DNA mà dưới ngưỡng phát hiện thì lúc đó ta dùng cái gì? Thì đây giáo sư đưa ra một dấu ấn là HBCRAG. Đấy, đây là một dấu ấn có dự đoán tốt hơn để phát triển và phát hiện ung thư biểu mô tê gan so với tải lượng HPV DNA. Thì những cái dấu ấn này giáo sư đưa đây chúng ta thấy là nó rất hữu ích và nó giúp ích cho chúng ta trong thực hành lâm sàng ở Việt Nam. Và sau này chúng ta nghiên cứu, ta theo dõi, chẩn đoán sớm, sàng lọc, theo dõi điều trị, theo dõi tái phát thì ta có thể ứng dụng những cái dấu ấn này. Cảm ơn giáo sư đã cho chúng ta những cái dấu ấn sinh học mới trong vấn đề chẩn đoán ung thư mà tôi thấy rất là ý nghĩa, rất hay và có lẽ cũng rất ý nghĩa thực hành trong thực hành ở Việt Nam. Nên cảm ơn giáo sư.
Xin cảm ơn thầy Hợp ạ. Vâng, chúng tôi muốn nhận được thêm nhiều các cái bình luận và câu hỏi ở trong phần thảo luận ở cuối chương trình. Một lần nữa xin cảm ơn giáo sư tiến sĩ David Pinato và thầy Hợp ạ. Xin mời tiến sĩ Vũ Quốc Bình.
Thưa hội nghị, là theo chương trình thì chúng ta còn 2 cái báo cáo của phiên toàn thể trong sáng nay. Thế thì cái báo cáo tiếp theo thì trước khi vào báo cáo thì chúng ta hình dung là nếu như chúng ta xem cái báo cáo đầu tiên của giáo sư Medhavan ấy, thì tôi rất ấn tượng một cái hình ảnh ở trên slide là